features or when you've tried treatment and it doesn't help, you don't necessarily have to reflexively image every vestibular migraine patient if the diagnosis seems pretty straightforward. I just want to highlight a little bit, which I thought was interesting, that migraine and stroke have a fair amount of overlap, and that's due to a few different things that happen in terms of the vasodilation and some of the vascular effects from some of those neuropeptides. And so this is important too. And I think that, when you have these patients, this may be a reason just to kind of ask some of these questions because migraine with aura actually carries an epidemiologically elevated stroke risk. And so when you get MRIs, like the picture at the next page, on the left side, you have a subclinical brain infarct on FLAIR sequences, and on the right, you have a white matter lesion in a patient with migraine. And so, you see this and you get an MRI, then you got to look at, kind of what your other findings are. And, if you should be worried about a stroke, you might have them see the neurologist for that reason as well, in addition to, potential treatment to rule out and kind of optimize if you're worried about them kind of having subclinical infarcts. And then on the right side, you can actually see that, there's a lot of white matter changes here. This is a chronic migrainer, and so they can actually be pretty severe as well. In terms of VNG, I'm very, very hesitant to kind of start VNG as the first thing for a lot of these patients. If there is a pretty obvious, chance that it is migraine, then I will usually tell them that, about half the patients that I send for vestibular testing and they're moving their eyes and shaking, that can trigger a migraine attack. And so, I would tell them I still want to be friends with them after they get their testing done. If there's a question about the diagnosis or they're pretty, confident that, or at least doubtful of the diagnosis, then sometimes it can be helpful to kind of look at Meniere's disease and rule that out or other, abnormalities associated with superior canal dehiscence. But I, again, don't generally start with this unless there's a good reason to do VNG testing. That's because you can also see a lot of kind of things that you're like, well, scratching your head about what does that actually mean? You see psychotic pursuit in 10%. You can see a unilateral hypofunction that then gets kind of becomes part of their diagnosis in 20. And about half the patients with migrainous vertigo had peripheral and central disorders at the time in one study. One thing that I thought was interesting, a study out of Vanderbilt that we used a lot when I was there, is that you can have patients with normal CVEMPs and unilaterally abnormal OVEMPs, and those patients are about 6.5 times more likely to be diagnosed with vestibular migraine. And that may just have to do with the differential innervation in the otolith organs that those deal with, but we're not exactly sure. It's just something that we have noticed. And so that's it for me.
Yeah, slight transition to how this is kind of seen in children before we get into treatment. Dr. Traboulsi?
Okay, thank you so much. So again, we're going to open a tiny parentheses and talk about vestibular disorders in children. The differential diagnosis, the diagnostic criteria of vestibular migraine is not very different between children and adults. Again, as Dr. Lindquist has mentioned before, the International Headache Society, along with the Barani Society, has reframed some of the diagnostic criteria. We have now what we call vestibular migraine of childhood. We'll talk about this in just a second. I wanted to start by saying that obviously the pediatric population is very different than the adult population. This is a population that is growing, the brain is developing. This is a population that cannot they cannot express themselves very well. And of course, the symptomatology of dizziness or vestibular disorders, or even just vestibular deficits without necessarily having dizziness, is a little bit different than adults. So we have to be familiar with some of these labels or some of these symptoms that may not sound like a vestibular problem or dizziness problem, but that may very well be a sign that something is going on with the vestibular system. Some patients are labeled as being clumsy sometimes or uncoordinated. Sometimes they have frequent falls. If the VOR is significantly affected in patients who have vestibular deficits, this can be translated into having learning disabilities if we're not able to read properly because of a deficient VOR. Some of these patients may display the imbalance in particular situations, in difficult situations, such as riding a bicycle or ambulating in the dark. So when we obtain a history in children, obviously, of course, depending on the age group, we can't just ask them if they're feeling dizzy. We have to look for some of these signs that tells us that something is going on. Interestingly as well, many studies have shown that patients with vestibular deficits have a history of delays in gross motor development. So this also has become a screening tool, a very useful screening tool especially in the pediatric hearing loss population for vestibular disorders. So many cochlear implant groups now will screen for vestibular disorders, partly by asking these questions if we've had delays in the gross motor development. So most babies are able to support their neck by the age of 3 months, and most are able to sit unsupported by the age of 6 to 9 months. And of course, most babies are able to walk by the age of 1 or 15 months. Some teams will accept up to 18 months as being normal. So this may be the first sign that we may have a vestibular deficit or vestibular disorder, especially in the context of pediatric hearing loss. Of course, as Dr. Lindquist has mentioned before, when we obtain a history for vertigo, of course, we look at the duration of the vertigo or the dizziness and the nature of the dizziness. In the pediatric population, I think another one comes into play here that can be very useful would be the age group. Of course, we're talking about children, but children also this population is also a spectrum. So when a patient comes to clinic, we have to look at this as an age group. Are we talking about an infant, of a young child, an older child, or an adolescent? And that alone can already give you a small differential diagnosis. Dr. Lindquist mentioned that vestibular migraine is the second most common vestibular dizziness in adults. In children, I would say it would probably be the most common one, especially if we clump together the different migraine variants, because in addition to vestibular migraine, which is definitely present in the pediatric population, I would say mostly in the adolescent group, we also have its equivalents in younger children. And the first one we are going to discuss is BPTI, or benign paroxysmal torticollis of infancy. We can go to the next slide. Again, this is also adding another funny acronym and confusing acronyms to the list of vestibular acronyms that we have. As the name implies, this is a condition that affects infants. And as the name implies, we have attacks of torticollis. Torticollis, sometimes it's to the left side, sometimes it's to the right side. Very often, these could be painful. If the toddler has already learned how to walk, we'll see sometimes a regression during these attacks. So just like any migraine attack, this is an attack where we have acute sudden symptoms, and then between the episodes, we have no symptoms at all. The physical exam is completely normal. Sometimes vestibular testing can show some abnormalities, just like Dr. Lindquist mentioned in vestibular migraine. This comes without warning. Sometimes we have some patterns, the patients are afraid, they don't want to move, and then this typically lasts minutes to hours, and then we are completely back to normal. What I like about this condition is that it sounds like it has nothing to do with ENT, and it's relatively rare. I think it's probably more prevalent than we think, because very often it's not recognized by pediatricians as an ENT problem. So I think that many patients are not referred to ENT, and just like many migraine variants, it resolves on its own, and then patients outgrow it. Recurrent vertigo of childhood would be the next one if you go chronologically. We used to call this benign paroxysmal vertigo of childhood, or BPVC, and to remove the benign part of it to make it less confusing, and the long list of vestibular acronyms that we have, we called it now recurrent vertigo of childhood. So in recurrent vertigo of childhood, this is the typical vestibular disorder of children that we learn in residency, where we have acute attacks of vertigo, typically lasts minutes to hours, very sudden, typically very severe. Again, a diagnosis of exclusion, just like many other clinical diagnoses or clinical vestibular disorders. And then between the attacks, we're completely fine. And then, of course, for the slightly older population, so older children or adolescents, we have the vestibular migraine of childhood, or what we call as well probable vestibular migraine of childhood, where the diagnostic criteria are a little bit more vague and less strict. I've learned that sometimes that line that divides RVC or vestibular migraine may be a little bit more out of focus, I would say, especially in children who are a little bit old for RVC or a little bit young for vestibular migraine. I would argue that it doesn't really matter to make a very clear diagnosis, whether it's one or the other, because it's the same pathophysiology, and the treatment would be the same as well. We can go to the next slide. We had talked about probable vestibular migraine as well. We can go to the next slide. I just want to mention a few items on the differential diagnosis in children. PPPD, I've learned that it's quite prevalent in children. This is a functional neurological disorder, as Dr. Lindquist mentioned before. Usually patients with PPPD do not have a room-spinning dizziness. They have a more vague description of their dizziness, whether it's a rocking sensation or a non-spinning dizziness. Most patients will have some anxiety. The overwhelming majority of patients who present with this will have some anxiety, and it may take a while to get rid of this. Many patients will require medications, typically antidepressants, along with vestibular therapy and cognitive behavioral therapy or biofeedback therapy as well has been described for patients. There's been a study that came out of one of the big pediatric groups that have found a link between COVID and having PPPD as well. And this, I think, is both in adults and in children as well. BPPV is also on the differential diagnosis. I will just make a small comment on the difference between BPPV in adults and in children. It was found that children, even though they have BPPV much more rarely than adults, but they are more likely to have atypical canal BPPV. So it's more common to have horizontal canal or anterior canal BPPV as opposed to adults, or multi-canal BPPV or recurrent BPPV compared to adults. So it's less common, but a little bit more complicated, a little more complex, and a little bit more resistant to treatment. In the pediatric population, we have a few more things as well that we have to take into that we have to consider. POTS is actually quite common, and what can be tricky with POTS is that it can also coincide with vestibular migraine. So it's quite common in children to have multiple vestibular diagnoses together, and it's important to recognize all of them. So I've made it a habit in my clinic to measure the heart rate of patients even before I see them while they're sitting versus when they're standing up, and a difference of 40 beats per minute is typical of POTS. The congenital hearing loss population as well, we have to recognize this. As I've mentioned before, many of these patients can have a congenital vestibular deficit as well. And we should not forget that many patients are born with syndromes and can have neurodevelopmental conditions, and we should take those into account as well when we obtain a history or when we examine patients. I think that's my last slide, if I'm not.
Yes, thank you so much, Dr. Traboulsi.
Sure.
So now to transition to the treatment, commonly in adults, but some of it is also applicable in children. But I think the treatment ladder always starts with the most conservative, which are lifestyle and trigger management changes that they can implement in their day-to-day. So the regular sleep schedule and dealing with OSA is a common conversation I have in my clinic, as well as staying hydrated and eating smaller snacks instead of intermittent fasting or some of these fad diets that are constantly being put out by social media. In our fast-paced world, of course, people rely heavily on caffeine and sometimes alcohol. So managing that, as well as the constant stress in people's lives, can also really come into some of our conversations in the clinic. Food triggers are a big topic, and I try to avoid that because it's such a big topic. But as you can see, this table is vast. And ultimately, I kind of generalize it to avoiding basically the extremes. Heavily salted foods, heavily sugary foods, lots of caffeine, lots of alcohol, as well as anything processed. And to most patients, it doesn't quite click, even though it seems to be a very simple task. I'll tell patients avoid the high salt diets, and they say, well, I don't add any salt. And then you ask a little bit more and you find out, and this is a true story, that they eat McDonald's every day. So you have to dive a little bit in order for them to kind of click in their minds that maybe there is room for improvement in their day-to-day lifestyle. And so I do have a handout for my patients just so they can refer to this, because otherwise it becomes a can of worms. And the reason these particular foods are indicated to reduce or limit is because they can induce tyramine and histamine release, which causes a series of oxidative stress. And what Dr. Lindquist was mentioning in that entire pathway from trigeminal all the way to the vestibular nucleus, you can have a lot of that, and that's why you have your diagnosis, vestibular migraine. This is a little bit more, and so if you wanted to kind of move them towards things that are a little bit more healthy, this is a different table. And so since this is being recorded, you guys can reference this in at a different time. During the acute treatment, lots of patients are already usually given meclizine by their primary care, by urgent care, or ER. And I typically tell patients to really try to put that away. It is a vestibular suppressant, but that doesn't allow you to overcome it. Mostly you're basically sleeping it off. And so you can't, number one, recognize the symptoms that you're having. So if you have a patient who isn't really the best historian, they can't exactly explain what they're feeling. And since so much of our diagnosis relies on their story, when they take meclizine, everything is kind of gray. So we try to avoid that. Certain anti-nausea medications are obviously helpful, with such as Zofran or prochlorperazine. And then the triptans I kind of reserve for the neurologist to prescribe or the primary care. And it does seem like that isn't really the most successful for vertigo symptoms, and mostly treats the headache component of the vestibular migraine. So when it comes to the maintenance therapy, I'll go into this in a lot more detail, but in general, I reserve this for when the patients are starting to have more consistent symptoms. There's a frequency to their symptoms, like every few weeks or every day. That is when the debilitating disease is necessitating something that's going to treat them every day. And this maintenance therapy, I overarchingly will tell them this is not going to get rid of all attacks, but it will sincerely reduce the frequency as well as the severity of each attack. And there are multiple different options, and I'm going to go into this in a little bit more detail, but just as a overarching bird's eye view, if they have hypertension that's not as well controlled, I'll lean more into the beta blockers as my first line option. Propranolol is supposed to be more effective than metoprolol. Calcium channel blockers such as verapamil is another choice. Anticonvulsants like topiramate, I will sometimes dive into, but very rarely. And most of the ones that I talk about are going to be the antidepressants, such as venlafaxine or nortriptyline. These the CGRP targeted therapies, I have never prescribed, but this is definitely the newest targeted therapy that's on the market for these patients. And then these supplements I give out like handy. It not only can help with some of the tinnitus, which usually these perimenopausal patients will have some degree of headache and tinnitus, hearing loss. So it helps with that as well as sleep. So this is kind of a typical thing that a lot of my patients are taking. When it comes to the triptans, they're really not that effective. For at least the vestibular component of vestibular migraines. So this was a clinical trial that showed basically no improvement, and they had to end this clinical trial early. Metoprolol also had no improvement compared to placebo, which was this Provemig study that was done, and they also had to terminate that because it really didn't work. So they showed that valproic acid, propranolol, and venlafaxine were superior to placebo in reducing these attack frequencies. This is pretty much my workhorse. Nortriptyline is much preferred over amitriptyline because it's more well tolerated by more people. So this paper showcased that 40 milligrams eliminated the symptoms entirely for their subset of patients. Interestingly, I think the teaching from neurology is that amitriptyline is best used for vestibular migraine. And so a lot of my patients who have come from neurology have actually trialed amitriptyline, but they have a lot of side effects such as xerostomia and somnolence. And so ultimately they feel like they can't take any of that class of TCA drugs, but it takes some coaxing to ultimately give them a shot with nortriptyline. So these are some of the drugs and also the side effects that are important to discuss. I'll tell you, when I was in training, my mentors never prescribed any of these. I never got any experience in that. And then ultimately, they always refer them to neurology. However, that's just not feasible in our system at UT. The neurologists are really backed up, patients are suffering. So I think as a whole, the field of neurotology and otology, ENT in general, has become much more comfortable with a lot of these drugs. And so that's why I put this slide on here so we can at least be familiar with it. I tell all my patients that and all of these, it goes for all of these, we start them at the lowest possible dose and then we work our way up. You start them off with nortriptyline 10, knowing that it's going to cause drowsiness, so it's intentionally taken at night. And then if they have any of these other side effect symptoms that makes them intolerable to the medication, we stop. And we trial another drug or another drug or another drug. However, if they don't feel any symptoms, they don't feel any benefit, side effects, I mean, then we will go up on the dose. The one caveat for venlafaxine, which isn't commonly talked about but is very important, is that you have to take it at the same time every day. Otherwise, you will feel some of these side effects. So I just make a comment on that. And then vestibular rehab is actually beneficial because a lot of patients will describe sort of like a chronic imbalance even in between their attacks. And when it's this constant imbalance that makes them fearful, they're no longer driving, they're not able to go to work, they're socially recluse, I'll have these patients do vestibular rehab, and it really does help. So when they have this persistent attack, persistence in between the attacks, it can really help. This randomized controlled trial in 2025 showcased that vestibular rehab helped with their dizziness, their sleep quality after an 8-week program. So if it's within their realm of possibility, I always have the patients do it if they can. So now we can move on to some clinical cases. Dr. Peng.
Thank you. Picked up these couple of cases because I feel like the people who come into our clinic are always not perfectly straightforward. So I kind of threw in a couple of interesting kind of things that might make you think, oh, would it be something else potentially? So let's delve into case number one. A 56-year-old female presents to your clinic with a sense of overall worsening hearing on the left ear and constant tinnitus on that same side, and also imbalance in the last 7 months. Denies any true spinning dizziness, vertigo, but also no fluctuation in this hearing. She did try the meclizine, but as Dr. Kaul had said, it makes people too somnolent, and it did do that for her. She does have a history of left PPVB years ago, which were corrected by Epley maneuvers, and during clinic visit, that was also negative. No other relevant history. Otologic does have hypertension and a unknown etiology of right eye defect. Now, her audiogram does show this asymmetric hearing loss, left-sided, moderate to severe sensorineural, and a word rec that is 76%. So I did do an MRI because of the asymmetric severe hearing loss. So what I'm just kind of throwing out for the panel, what would you do next for this patient who presents to your clinic? Any other imaging, any testing? Would you go straight to talking about, some of the things that Dr. Kaul talked about, dietary changes? And what do you think really the differential could be for this patient.
I mean, I think that vestibular testing could be useful. It could show an uncompensated loss, and then vestibular rehab might be reasonable for her based on her imbalance.
Mhm.
Um, was it like an acute episode that this happened, or has it just been slowly progressive?
Progressing over the last 7 months.
Yeah. So, I mean, this is really kind of a tough one because it could be a bunch of different things. You could think about 3PD. You could think about some neurologic issue in combination with a peripheral issue. She
Mhm.
has autoimmune disease in her history, so it could be some kind
Exactly.
of, autoimmune.
Was the BPPV 7 months ago prior to the onset of her current
It
symptoms?
was several years ago before
Okay.
this onset.
Okay.
Yes.
What's her exam? Yeah.
Totally normal otherwise. Yep. No head impulse negative. All bedside testing was negative. So let's go to the next slide. So I did order the VNG, and while I was ordering, I had it. It takes a little bit to get the VNG, so I asked her to go ahead and start on a low sodium diet. And she was a big caffeine drinker and loved her alcohol, red wine at dinner with every dinner. So we talked about kind of lifestyle changes as well. And sure enough, the VNG did show left-sided vestibular weakness, and the rest of the testing was negative. I was unremarkable. VEMP was normal, and no rotary chair testing was also normal. However, she continued to have symptoms. The next slide here. She started to actually have true vertiginous symptoms, lasting now more than a day, with newer complaints of brain heaviness and phonophobia after each of the episodes that last, pretty much the whole day. She does feel like when she takes naps and rests, she feels better. But then, even after those episodes, she feels a sense of imbalance. Whenever she goes on flights, it gets worse. She's a avid horse rider, and when she's riding, after she rides her horse and gets off the horse, she also feels very vertiginous. I did start her on magnesium and B2, and this is a point where I decided to refer her to a neurologist. What do y'all think? Would you have done anything different?
I think I would have also added vestibular rehab since, it takes time to get into the neurologist and patients
True.
like to have an actionable item, even if there's not a drug.
And I didn't mention on my slide, I did ask her to go to vestibular rehab along with the modifications. Thank you. Yeah. And like you said, it was going to take about 2, 3 months to get into the neurologist. So I actually started her on the verapamil. My drug of choice is actually verapamil. That's based on what I used in fellowship, mainly because the main side effects is constipation. And I feel like constipation may be a little bit easier to deal with than drowsiness, especially from work or whatnot. My years of experience, I had a couple patients who developed palpitations from the use of the verapamil. Usually I start with 120 milligrams of extended release for a week, and then I go up to 240 milligrams extended release thereafter. Usually it takes about a month or so for anybody to respond to that dose. So if they don't get better after that 1 month, I usually say, well, probably won't continue it if it's not helping, and then I'll kind of defer to the neurologist. And with the neurologist, she was started on neurotech, but unfortunately, she was not able to tolerate because of GI issues. But she actually was given Botox and really helped her with her dizziness because she started to have these other migrainous features, which case the Botox actually helped. So she has been well maintained with the Botox. All started with a left-sided hearing loss and asymmetric hearing loss. So case two, we have a 40-year-old female, another female actually with a 9-year history of worsening hearing loss and vertigo. The vertigo lasts for about 20 minutes to 2 to 3 hours. She does have baseline tinnitus and sense of fullness in the right ear that's constant, but it is worse. It does get worse when she has the vertiginous symptoms. She has true vertigo. The hearing loss does improve once she stops having the vertigo. However, 6 months ago, after a pretty severe URI, not COVID, patient developed disequilibrium that lasted all day, along with persistent hearing loss and tinnitus. And ever since then, her symptoms just continued. She does have vision changes associated with loud sounds, almost like Tullio's, but no autophony, and reports of having this, in her words, brain fog that lasts for 30 minutes to 6 to 8 hours. Patient also does admit to having a history of migraines, but has never taken any medications. No other otologic history and is currently on a low salt diet. Even though she goes out and eats out several times a week. She has those other medical issues, including a cardiac murmur, and she has seen other people who thought that she may have potentially Meniere's and had tried diazide, which she takes on a daily basis, beta histone on 8 milligrams 3 times a day, citalopram, and Valium as needed for anxiety. For somebody, and this is her audiogram demonstrating that she does have a right-sided hearing loss. And then in subsequent visits, you can see another audiogram that shows an improvement in hearing up to word rec of 100% and almost, symmetric hearing to the left. And then returning yet another visit, having worsening hearing again, back down to word rec of 24 and moderate severe hearing loss. Imaging was negative, and the VNG was consistent with a right vestibular weakness, with compensation noted on rotary chair. Now, so this is the main question I want to ask everybody. I think that sometimes is a head scratcher. Well, is this a Meniere's patient? Is this a vestibular migraine? A combination of both? And potentially 3PD or other type of, other differential? What does the panelist think? Or anybody in the audience happy to chime in?
This is a really hard one. I would lean towards vestibular migraine as the primary treatment, but co-treating her with Meniere's and vestibular migraine therapies is probably your best shot at getting her feeling more normal. You can't deny the hearing loss that's been documented on different occasions. So this is tough, but I would definitely lean into giving her a lot of the migraine treatment. The way that I kind of frame it is like if your brain is clouded, constantly being plagued by migrainous symptoms, even if it's just regular headache, there's no way you can function well at all in any other arena of your life. So you have to have that fully clear. And if you have inner ear subsequent other problems, those can be much easier. Those can be treated much easier than if you're not dealing with this neurological deficit and you're only targeting the inner ear.
I was
Thank you,
gonna,
yeah.
it's always interesting to try to put them on a diet for both Meniere's disease and migraine too. So you're basically having the restrictive, you know, uh, foods that can be healthy, right? So avocado, figs, papayas, but then you're also trying to limit all their salt, in addition to MSG and anything else that looks like a neurotransmitter. So, um, I guess that's kind of where I'm like, well, you got to have a where you got to combine both of those things, and they're like, I'm not sure this guy knows exactly what he thinks is, or, what is going on here, but I really do think it probably sounds like a combination of things. And do you say this patient was on magnesium and B2? Because those are low-hanging
I
fruit.
put her on magnesium B2
Yeah.
after, yeah.
Those are low-hanging fruit that are pretty easy for people to get. And the nice thing about those is, there's some diarrhea as a side effect if you start too high, but I think most of the time people are able to tolerate them well, especially
Mhm.
the magnesium glycinate. And I know you said CT scan was normal. I mean, she has some kind of sound like she almost had a third window or something too on top of all that. So I mean, she just might have a little bit of everything, which makes it tough.
Yeah. So I did start on the magnesium B2. We talked about the food diet, low salt. Again, I went to my go-to with the verapamil, and she actually started to feel better. And usually it actually came back at about 3 months later and said she started to have issues again. Her severity is less, but it is still present. So next step then. I kind of went the same route as Dr. Call. I really was trying to focus. Like I think she did have, or she does have both processes going on. But I talked to her about the central aspect of her dizziness, and that when everything is hypersensitive, you really need to try to calm that down before you can even manage the Meniere's aspect of things. So we really concentrated on that. So she's really working on that lifestyle change, and we sent her to PT to get her some vestibular rehab. Thank you so much for your input.
That's it for our little webinar.